Darius presented with many signs and symptoms of PANS, with an abrupt onset of OCD and neuropsychiatric symptoms, including choreiform movements, hyperactivity, light sensitivity, and regressed behavior. In this section, we will review lab evaluations, working to identify both antecedent conditions such as strep and to exclude other diagnoses. These evaluations will help prepare us for anticipated treatment of infection and inflammation. This section will cover the diagnostic evaluation for PANS. Lab evaluation begins with ruling in or ruling out infection. We suspect that Darius may have a Group A strep infection. A throat swab for Group A strep is recommended during the initial diagnostic evaluation for PANS, regardless of the presence of clinical pharyngitis or the severity of neuropsychiatric symptoms at that time. A throat swab should also be performed both during exacerbations of neuropsychiatric symptoms and during episodes of pharyngitis. To test for strep, the throat swabbing should be vigorous and must include the posterior oropharynx and tonsils. Since up to 17% of strep cases may be missed by a rapid strep test, a specimen should be sent for strep culture if a rapid test comes back negative. If sending a swab for perianal, vulvar, or wound strep, specify that you are looking for strep. In PANS patients who have had strep identified, asymptomatics should be evaluated on a case-by-case basis. They are at low but not zero risk of transmitting illness. Since one exclusionary diagnosis is rheumatic fever, adhere to the American Heart Association's guidelines for a rheumatic fever evaluation in the resource section of this course. Darius had no signs of rheumatic fever on exam. While Darius did not, if the patient or family member has a persistent, non-productive cough, consider the diagnosis of Mycoplasma pneumonia. A swab for Mycoplasma PCR is more accurate than Mycoplasma IgG and IgM titers. Other wound and viral culture should be done if the clinical presentation suggests, as in cases of impetigo, cellulitis, and influenza. Opportunistic or occult infections, such as tuberculosis, endemic fungi, and hepatitis B, are checked as part of the immunodeficiency workup or prior to immunosuppressive treatment. If one is unsure of an appropriate evaluation, consultation with an infectious disease and/or immunology rheumatology specialist may be helpful. Sometimes, no antecedent infection or trauma can be found in a patient with bona fide PANS. Blood tests may be helpful in diagnosing infection. An interesting prospective study of measurable immune responses to Group A strep can be found in the resources section. Anti-streptolysin O and anti-DNase B titers can offer clues about recent or past strep exposure, but one measurement is inadequate to make the diagnosis of strep infection. Most children will have been exposed to strep and will have antibody levels, although some children with documented Group A strep infection do not produce these antibodies. A marked change in titer indicates a recent Group A strep infection. As a result, single ASO and anti-DNase B titers are not conclusive tests for PANS. A panel of serum antibody evaluations is available, but it is not diagnostic for PANS. If Darius's strep culture is positive, we do not need to check strep antibody titers. If we have missed the opportunity to culture for strep, then checking the titers could be informative. The choice of other blood tests depends on presentation, history, and family history. Blood tests such as inflammatory markers, if abnormal, may help in tracking flare and remission status and rule out other diagnoses. Ongoing research suggests the role for monocytes in inflammations associated with PANS. If non-steroidal anti-inflammatory medications are considered, as we may do with Darius, a baseline complete blood count, complete metabolic panel, and urinalysis are necessary. In addition to cultures and blood tests, other diagnostic procedures may include MRI, LP, and EEG. Brain MRIs may be helpful when other conditions, such as central nervous system small vessel vasculitis or limbic encephalitis, are considered. MRIs are also indicated when the patient has severe headaches, gait disturbances, cognitive deterioration, or psychosis. They may be helpful in identifying occult sinusitis. Consultation with a radiologist who has expertise in vasculitis can ensure that you order the proper MRI procedure. An EEG is appropriate to rule out seizure disorders. We have found abnormalities, including electrical status epilepticus in sleep, or ESES, and other subtle EEG abnormalities. Sleep EEGs have revealed REM motor sleep inhibition disorder, where patients move during their dreams, which can indicate basal ganglia dysfunction. Consultation with a pediatric neurologist can help guide ordering and interpreting these procedures. Lumbar puncture should be considered if there are MRI or EEG abnormalities or encephalopathic symptoms such as delirium, alteration of consciousness, seizures, or psychosis, or if an autoimmune encephalitis is suspected. We did not do a lumbar puncture on Darius because he did not have these findings. In summary, the purpose of laboratory evaluations is to rule out other diagnoses and prepare for anticipated treatment. There is no single laboratory test for PANS. The diagnosis is made by observing the sudden onset of specific symptoms. In Darius's case, both his throat and perianal strep cultures were positive. Other lab, MRI, and EEG findings were unremarkable. Dr. Jones felt that other diagnoses were excluded and thought that Darius was most correctly diagnosed with pandas, a type of PANS. In the next section, we will discuss gathering a team and initiating first-line treatment.